So I'm Adelina Comaserera, and I'm delighted to welcome you to today's webinar of the Global Observatory of Long-Term Care, and this time it's a quasi-experimental methods interest group webinar. I'll very briefly introduce the observatory as well as our forthcoming webinars, so you know what's coming next. And so the Global Observatory of Long-Term Care is a platform for cross-national learning on how to improve and strengthen long-term care systems. And we're particularly interested in sharing research evidence, like in today's webinar, and then thinking about how this can impact policymaking. It's open to everyone. As we said, it's all about sharing. And the way we do that is through our own publications. So we have long-term care system profiles, blogs, methods, and topic guides. We have interest groups like the one today from the quasi-experimental methods. We also have other interest groups that are focusing on particular topics, other methods, or even in particular countries and parts of the world. So we have one on Latin America, we've got one on Spain, we've got one on China, Southern Africa, and Australia. And we're gradually building up a database of experts on long-term care. So those of you who sign up as members and people are listed by country, topics, and methods, we're building a repository also of publications on long-term care, research projects, and quite a large library by now of previous webinars where you can see the videos and also see some of the publications and slides. Our next webinar is on the 13th of July, is from the Innovation and Long-Term Care Interest Group, looking at embedding design principles for cross-boundary collaboration in long-term care, with some examples from the UK. We then have one from Spain. We're going to be looking at the proposal for reforms of the laws of disability and dependency. This will be in Spanish, so if you want to practice your Spanish, do join us, as well as finding out what's happening there. And we have one then on the 7th of October, looking at care for older people in the context of the war in Ukraine. So as you can see, we've got a lot. There will be more that will be announced soon during the summer for September, October. And I just want to say how pleased I am to host today's webinar and handing over to Javiera, who's going to introduce the interest group.
Thank you, Adelina. I'm going to share now. Can you see? Can you see?
Yes, perfect.
I'm going to minimize you. Oops. Okay, so thank you, Adelina. Thank you very much. The quasi-experimental method interest group main motivation is to bring together academic and policymakers and practitioners with an interest in knowing how we could better evaluate causal effect of long-term care policies and interventions. So we want to know what works on long-term care, and in this sense, we believe that methods matter and they can have a real impact. For obvious reasons, this interest group is strongly methodological, but we're also very welcoming, and we want to provide a platform for knowledge exchange and generating new methodological ideas. So everyone is welcome, and if you know anyone who wants to be part, please share the link that is in the chat that Nas just shared with everyone. So I like to show some stats of the group every time we meet. So we are 115 members. That was the last time I checked. So we have expertise from more than 40 countries. And in general, I would say that the group is quite popular among researchers. So we have 109 researchers, but we are failing a little bit on including people from the policy side and also practice or advocacy. So we have very few members. And again, if you know anyone who will be interested in joining, please let them know that we exist. If you go to the quasi-experimental method interest group, you can, Nas put the link, you can join. There is a very short form, it's just your name and a few details. And also you can add other interest group that are part of the Global Observatory. You can look at the members of from the group. You can also look at the recorded webinars that have happened in the past. And there's also some suggested reading. If you have any paper also that you want to include in part of that list, please let me know. I'm happy to upload them. And also we have other resources, including topic guides. So I think at the moment there are 4 topic guides on regression discontinuity result in propensity score matching, difference in difference, and synthetic control group. And they are very, very short pieces of work where the methods are explained in a very simple ways, and also some example of how they have been applied to long-term care research. So they are quite useful for those that are just starting learning quasi-experimental method. And well, that's my email address in case you want to get in touch or you have anything that you want to share, or if you want to present in the future, I'm also happy to arrange that. So thank you. That's all from me. And now, Diane, over to you. I don't know if you want to present yourself and the topic, I guess.
Yeah, that sounds great. Thank you. Let me just get up my slides, make sure I'm all set up. Okay. Can everyone see the slides and hear me okay? Okay, fantastic. Thank you all so much for being here. Thank you for having me. I'm very excited to be here and happy to share my work in progress research, which is looking at the effect of being in a private or a shared room on nursing home resident health outcomes. Again, to introduce myself, I'm Diane McWilliam. I'm a PhD candidate in economics at the University of Michigan. Probably hear from my accent. I'm not American, I'm from Australia, but very excited to talk a bit more about my research. And feel free to jump in with any questions. I think someone will help me monitor the chat, but hopefully I think we also have time afterwards. Okay. All right, so I'd love to start with a little bit of motivation. Why is this interesting? I probably don't need to motivate it too much with this group, but I think in many countries around the world, but especially the US, there's a large and rising public spending on nursing home care. In the US, nursing home care is largely government funded, but also in the US, the nursing home industry has really been plagued by some persistent quality concerns, which I think were really highlighted in the COVID-19 pandemic as well. So the industry needs systemic change, which I think has raised some interesting, very broad questions, just like, how much do we value health versus non-health dimensions of utility in our old age care? What should taxpayers be funding? And I think these broad questions are really front and center in one potential solution that's been proposed for these quality issues, which is we need more private rooms. In the US, there's been some national and some state policy interest in promoting the supply of private rooms very recently. And we know that older adults generally prefer private rooms, but private rooms also cost more to provide. Medicare in the US doesn't differentiate the reimbursement rate based on whether you get a private or shared room. So really, there's this question of should policymakers actually be incentivizing nursing homes to provide more private rooms. But when I'm thinking about that, I thought it was surprising that we don't actually have evidence on whether private rooms are better or worse for resident health. So that's my research question here. Do private rooms actually improve nursing home residents' health? Before I get started, I guess just to set the scene for what I'm trying to do in the paper, think about maybe 2 friends who have hip replacements. So they go into hospital, say the same hospital, let's call them friends Alice and Barbara. Imagine Alice leaves the hospital at a time when there's a private room available in the nursing home. So she gets a private room, but say Barbara leaves a week later on a day that there's no private rooms available and only shared rooms. So she ends up in a shared room. Imagine a few weeks pass and Barbara maybe is discharged home back to the community, expected to make her full recovery, whereas Alice is maybe readmitted to hospital. So there's some difference in outcomes. And I think, the idea here is, could that difference in outcomes be because of the type of room that they receive? And I think this is an interesting question because, the effect of a private room on outcomes is really unclear ex ante. So this is the key relationship that I'm interested in, the effect of a private room on primarily what I'm calling final health outcomes. So did the resident die? Did they go back to hospital? Were they discharged home? And particularly, I'm looking at outcomes here for short stay residents, which is, I think, a unique group, particularly in the US, that I'll tell you a little bit more about in a second. But really, I think there are three main channels or mechanisms through which private rooms could have an effect. So the first is infection control. You might, imagine receiving a private room could be better for your likelihood of, you might be less likely to contract an infectious disease. There's some evidence suggesting that, but there's also evidence showing that maybe there isn't an effect. The flip side of that, I think, which was also highlighted in the COVID pandemic, is that there could be effects on what I'm calling mood, right? So private rooms might mean the residents are more isolated socially. They don't have companionship, which could be worse for health outcomes. On the other side, maybe private rooms allow residents to have more control. They can control the temperature, the noise. Maybe they have more visitors. Maybe they have less roommate conflict. So maybe they're better off. And then finally, I think there's a quantity of care channel here where maybe if you received a private room, you're more satisfied with the room, so you're more likely to stay longer, receive more care. On the other hand, you don't have a roommate, so maybe you're not receiving monitoring from the roommate. Maybe staff are coming by less frequently, so maybe there's less daily care. All of that is just to say that there's lots of stories you could think of how the effects could go either way, which I think make it interesting. And I will try and kind of see if I can shed any light on these mechanisms by looking at some intermediate health outcomes. So at the moment, I'm, trying to get at proxies for each of these channels. So looking at things like, did the resident spend time in isolation during their stay? What was their change in depression score? What was their length of stay? But yeah, all of that is to say it's, I think, unclear the direction that we'd expect. This work, I think, contributes to two main strands of literature. The first, quite specifically, is looking at what's the role of room type within nursing homes. Most of the work here has really been descriptive. There's some barriers, I think, that have prevented us having causal estimates. The main one being that there's the key challenge here is that residents are very likely to be selecting into rooms in a way that's probably related to their baseline or underlying health. So we need some kind of randomness, some kind of exogenous variation, which is what I'm bringing here, and I'll share in a second. Also, at least in the US, we haven't really had data on which residents receive which types of rooms. So I'm also contributing there. I'll mention there's some very recent, closely related work in progress by Cheng and Hackman. They're looking at what is the characteristics of your roommate and how do they matter for your outcomes, specifically looking at whether you have a roommate that has Alzheimer's disease or related dementia. Here, I'm focusing on a different margin, which is, do you receive a private or a shared room, which I think is particularly interesting when we're thinking about, incentivizing construction of new rooms or renovating rooms, or, what rooms should we actually have? But yeah, I'm providing some of the first causal evidence of the effect of receiving a private room on post-acute nursing home residents' health. More broadly, I'm also, contributing to this growing literature on the economics of nursing homes. A lot of work here has looked at, what determines nursing home quality, but I think most of the work has looked at differences across facilities. Only a couple of papers really looking at quality differences within facilities. So I think I bring to that room type as an understudied source of within nursing home quality variation. And my estimates allow me to try and quantify, how much does the physical environment of healthcare production matter relative to maybe some of the more well-studied inputs, like staffing. Okay, just a little bit more background before I dive into the data, because I realize the US maybe is a bit unique compared to other countries in the sense that in our nursing homes, there are two distinct populations. So there's what I call post-acute care residents, or sometimes called short stay residents. So these are residents that are coming straight from hospital, going to a nursing home to recover from surgery or some kind of other acute illness. They're having skilled nursing and rehab services following the hospital stay, and they're staying for a number of weeks or months, and then ideally going back home. And then there's the other group, which is long stay residents who you might maybe have thought of more, who are residents who are no longer able to live independently, need help with activities of daily living, often stay for the remainder of their lives. So I will focus on outcomes for the first group, and I think they're attractive for this setting for a number of reasons I'll say a bit more about in a second. But you might also, I think, be wondering, what do we know about how residents are actually assigned to private versus shared rooms? So from talking to nursing homes and from the limited amount of information I think that's out there, I think in practice there are three main factors that determine whether someone gets a private room. First is if someone has a medical condition that means they need to be isolated, then they'll definitely get a private room. I think gender matters because there's same-sex rooms, apart from in the rare cases where couples are married. And then thirdly, the availability of private rooms matters. But you also are probably thinking, okay, there's many other additional factors that might shape it. Some of these are observable, like the ones I just mentioned, but then there's a lot of unobservable factors. Maybe certain residents are able to, or their family are able to advocate for a private room. Maybe there's pre-existing relationships with the facility. So really, there's this, selection issue in terms of unobservables. And what I'm doing here is I'm leveraging, I think, plausible exogeneity of private room availability to help me overcome those selection concerns. Okay, so talk a little bit about the data I'm using. I'm linking two main administrative data sets in the US. So the first is the minimum data set. Maybe some of you have heard of it. I think really amazing that basically every nursing home resident in the US has regular standardized clinical assessments during their stay at admission, quarterly, and at discharge, and then for the post-acute residents, also at days 14, 30, and 60. So I'm using that for all residents in the US over 2017 to 2019, and that gives me access to a lot of rich variables and information about their health status during their stay. So their physical, cognitive health, mood, medication, behavior, lots of interesting stuff. I think one of the key variables I use, though, is room number. Basically, recording for each resident, am I in room 101? Were they in room West 23A, for example? And I use what I think is quite a novel procedure here to determine whether a resident is in a private or a shared room based on that room number. Basically, I'm just if you can look at all residents within a nursing home at any point in time, if there's more than one resident in the same room, then that's going to be a shared room. And then I can also back out the availability of beds in those rooms. There's a lot more work to that than I'll share that we have time for, but if you have questions, I'm happy to talk more about that. And then I link that to Medicare claims history and enrollment data. And that allows me to focus on specifically outcomes for the post-acute care group, and specifically those that are funded by traditional Medicare. And I think, several advantages, but one of the big ones is that helps me, I think, minimize concerns that you might have that, okay, well, what if residents are selecting into nursing homes in line with the availability of private beds, right? In the case of post-acute residents, they're coming straight from hospital. They have very limited time, less than 24 hours to shop around for which nursing home they want to go into. And they don't really know most of the time at all about whether private rooms are available or not. So that helps me with that kind of selection concern. And it also lets me look at health status before residents enter. So I have, the baseline health controls as well as after the nursing home stay. So I can observe, did they die? Were they readmitted to hospital? Can I drink? Okay. So just some very high level summary statistics. Really, if you just look at like the naive means, and here I'm showing you all my residents, the post-acute care residents, split by whether they received a private room or if they received a shared room. If we just looked at the naive averages, it would probably suggest that residents going into private rooms have better final health outcomes. Slightly fewer, slightly lower likelihood of dying within 90 days or going back to hospital in 90 days, maybe slightly higher likelihood of going back to home in 90 days, which is seen as a successful outcome in the case of short stay residents. And then if we looked at their baseline health as well, looking at some of their, clinical characteristics before their nursing home entry, you might also think, okay, maybe those in private rooms were healthier on average at baseline, slightly lower likelihood of having Alzheimer's disease, slightly lower length of stay in the previous hospital stay, maybe slightly or, about the same risk level. But of course, as I mentioned, it's likely that residents are selecting into rooms, and that's the big kind of empirical challenge here. So I want to address this endogeneity, and specifically, I'm using an instrument to get past this, which specifically is the private room availability, the number of private rooms available in the nursing home that the resident's entering into on the day before they enter, as some kind of exogenous, shock to whether they get a private room or not. So what does that look like, this private room availability measure? Here I'm just showing you a histogram. So along, the horizontal is that instrument. What is the number of private rooms available on the day before they enter? And, the percentage of residents entering on those days. And you'll see that really the bulk of residents, about 80%, are entering when 5 or less private rooms are available. So that's the key kind of variation that I'm using here. Okay. Ooh. All right. In terms of, methods, I'm running two-stage least squares regressions. I won't go into all of the detail, but I think for the first stage, the key things to know is, what is my endogenous independent regressor? It's an indicator for whether a resident receives a private room or not. It's 1 if they receive a private room, 0 otherwise, which means they get a shared room. And then the other key variable on the right-hand side is my instrument. In the baseline, the functional form I'm using is 5 indicators for whether there's 1, 2, 3, 4, or 5 plus private rooms available on the day before you enter. Basically, I have a lot of the other additional controls that you'd probably expect. So, I'm looking at within nursing home variation. I have nursing home fixed effects. I have, some time fixed effects, controlling for some resident demographic and clinical characteristics at baseline. Importantly, I also have control for the daily total occupancy in the nursing home. You might be worried that, okay, maybe what if whether a private room is available is just reflecting the overall crowdedness in the nursing home. And, maybe a more crowded nursing home means that staff are more, run off their feet, and that leads to worse outcomes, in a different way. So controlling for the total occupancy. And then, the second stage is as you'd expect. In terms of the validity of the instrument, I'm running 2 main kinds of balance tests here. I won't show you the all the tables and regressions, but to summarize what I'm seeing, for the first one, I'm just doing, standard balance tables, stratifying the sample based on values of the private room availability instrument. And it looks like, based on about 40 different resident and nursing home characteristics, very well balanced across. But then I think I go probably one step further, where I'm running 40 different regressions of each baseline resident characteristic or nursing home characteristic onto the availability instrument. And of these, there's only maybe 4 that are statistically significant and very small point estimates, kind of economically not meaningful. So what I take from that is that it seems like private room availability isn't really systematically correlated with a large number of observable resident characteristics or lagged nursing home quality. Basically, the types of residents entering on days where there's high availability and low availability seem to be about the same. So that's good. And then move on to, estimating my first stage. Before I show you that, I guess just intuitively, what's the relationship we'd probably expect? Well, I think starting from 0 with the first private room available that becomes available is probably going to matter the most for whether you receive a private room. Then the second one will matter more. The third one more, but maybe at a little bit less than the first. So there's probably going to be some kind of non-linear relationship. And then you'd expect that we'd get to some point where each additional private room available doesn't seem to actually matter for whether you get one or not. And that's exactly what I see borne out in the data. So let me explain this graph to you. This is basically my first stage estimates. On the horizontal, I'm showing you for all 20 indicators of the number of private rooms that were available, so the instrument on the horizontal, and on the vertical, what is the estimated effect on the probability of getting a private room. So, in these regressions, I have all the controls that I showed you before. And yeah, as you can see, the first private room available matters the most in terms of increasing your probability. The second one matters a bit more, but slightly less. And eventually, by the time we get to about 5, kind of plateaus. And also remember that the bulk of the observations are around 5. So that's kind of the reasoning for why I use my the indicators for the first 5 variables as the functional form. Okay, here again, I'm just now showing you, in numbers, what are the point estimates for each of the number of private rooms available, 1, 2, 3, 4, or 5 plus. Just to kind of summarize, the key takeaway here is that the availability measure, I think, is a strong predictor of whether you get a private room, an F-stat of about 145. How would we interpret, say, the first estimate? Well, the first private room that's available increases your probability of getting a private room by about 5 percentage points, which relative to about 10% of people on average getting private rooms, that's about a 50% relative size. And each additional room available increases your likelihood, but at a decreasing rate. Okay, so hopefully I've convinced you that the instrument's valid and it's a strong first stage. So I'll share my preliminary estimates. Again, fairly preliminary. There's a little bit more robustness tests I want to do here. But what am I seeing so far? I'll talk you through the IV estimates first, and then the OLS. So when we look at the outcome of did the resident die within 90 days after they enter the nursing home, for that, the IV estimates are statistically insignificant. If you looked at the direction, it would be suggesting that private rooms are worse. How precise are my estimates? I can rule out private rooms causing an improvement of more than, say, 1.9 percentage points in terms of 90-day mortality, which is about 12% of the mean. I think that's about a similar effect as has been found for the effect of private equity acquisitions in nursing homes on 90-day mortality. But so insignificant in terms of death. If we look at did the resident go back to hospital and have a hospital stay within 90 days after entry, I do seem to find some kind of effect there that receiving a private room in my baseline estimates increases your likelihood of going back to hospital by about 5.6 percentage points, or 17% relative to the mean. And then if we look at what is seen to be a successful outcome, did the post-acute resident go back home? Specifically, did they discharge straight to home with self-care, without any home health within 90 days? We have a negative estimate, so that again is consistent with private rooms actually being worse, and leading to about a 16.1 percentage point decrease in the likelihood of discharge directly home, or about 37% of the mean. I think interesting to then compare these to the OLS estimates, which I'm showing you in the first row now. When you compare them, it seems that the IV estimates are generally opposite in sign, much larger magnitude, which I think suggests that there is some downward bias in these OLS estimates, which is consistent, I think, with healthier residents selecting into private rooms. I think ex ante, we didn't really have any evidence, so we're not sure whether it's the healthier residents that are selecting into private rooms or the less healthy ones. So I think that's additional kind of interesting finding here. Okay, so given I'm finding some significant effects in terms of hospital readmission and discharge home, I then look at trying to investigate what are some of the potential mechanisms that might be causing this. So like I mentioned, using some proxies for each of these 3 channels that I outlined. So for infection control, I'm looking at, did the resident, for example, have a period of isolation for active infectious disease during their stay? For mood, what was the change in depression symptoms or behavioral symptoms? In terms of quantity to care, were there effects on length of stay? Again, these are not perfect proxies, and I'm, still working on this, trying to look at if there are better measures. But without showing you all the results, just to summarize, at the moment, I'm not finding any evidence of a significant relationship between getting a private room and these intermediate health outcomes, and generally imprecise estimates. So inconclusive there at the moment. Okay, so I'll just conclude, summarize this paper. What am I doing? I'm using the universe of clinical nursing home assessments to help me determine whether someone actually receives a private room and the private room availability using this key room number variable. And then I'm leveraging, I think, high frequency within nursing home daily variation in the availability of private rooms to help me get at what is the causal effect here of private rooms, specifically on post-acute residents' health in the US. In terms of my preliminary results, like I just showed, I'm really not finding any strong evidence in support of private rooms improving post-acute residents' health, at least on average, which maybe is surprising given we know, older adults prefer private rooms generally. Statistically insignificant estimates on mortality and on some of my proxies for the different mechanisms. But in fact, I do find some evidence that private rooms are actually worse for health in some cases. So private rooms seem to be, decreasing the likelihood of discharge directly home within 90 days and increasing the likelihood of readmitting to hospital within 90 days. And again, I think important that the IV estimates really highlight, comparing to the OLS, that selection is an issue here, and why it's important, I think, to adjust for that endogeneity and show that there otherwise it is that healthier residents are selecting to private rooms. Again, preliminary results, but what do we take from this so far? I think policymakers that are seeking to improve, particularly health, perhaps should consider prioritizing other nursing home quality improvement initiatives that do have, more proven effectiveness and evidence. Maybe, minimum staffing levels, for example. At least that is among the specific population that I'm able to estimate for, which is Medicare post-acute care populations. And one of the big caveats here, I think, is that though optimal policy, should ideally also account for non-health dimensions of utility from private versus shared rooms, right? Health is not necessarily everything that we care about. It's just that these are, I think, a lot harder to measure. So next steps, where am I going? I didn't get to talk about all the robustness tests I've run so far, but I have a few more that I'd like to do. I think really important that I'm working on at the moment is looking at, okay, is there heterogeneity in the effect of private room receipt? Specifically, I'm thinking in terms of some resident observed characteristics, like does the resident have dementia? What's their risk level? And nursing home characteristics. You'd imagine that, maybe for certain people, private rooms are better than for others. And I think that's very important in terms of, allocation decisions if we have, fixed capital. I will also hopefully look at alternative endogenous explanatory variables. So things like I can measure, what's the percent of your stay that you actually had a roommate present, which will help, I guess, kind of more get at the dosage effect of how much were you exposed. What's the percent of your stay that you did spend in a private room to help me account for movers. I think moving rooms is not very common, but that would be nice to look at. Okay, I think that's all I have for today. I would love to hear your comments, questions. Now, also feel free to email. Yeah, really interested to hear your thoughts. Thank you.
Thank you very much, Diane. Agustin, do you want to take over now?
Thank you very much, Javiera, and thank you so much, Diane, for your presentation. I like so much the way you introduced the problem with the examples of these two persons, that one of them is in a private room and the other in a shared room. And in general, I'm so shocked about the results because I didn't expect that the private rooms was these multiple bad effects. I see the results. So considering that you have a huge samples, all the tests that you're going to run are going to be always significant. I think it's better if you introduce some side effects between the means in the mean result presentation when you share the two means, because I don't know how much is the effect size, but I guess that is maybe medium or maybe medium large, depending on the difference. And
sorry, you're saying show the significance of the differences?
yeah,
Did I
the
hear you correctly?
significance and the effect size, maybe a decoin or something like that, or maybe a probability of the difference, because it's something to consider, to have a relative amount of the difference. And I was thinking in two main questions when you are speaking about, because for example in Spain we don't have this kind of private framework in our facilities, in the hospital or even in the residences, because the people in the public system that we have here, we don't have the choice maybe sometimes to share the room. When you go to the hospital, you always share the room. So I'm thinking in the external validity of your results, because maybe it's so interesting to compare the data. We can find another set of data in Spain or another country like in Spain to compare your results with this kind of context. Yeah, and I was also wondering if you say that you cannot find a specific measure of well-being or emotional or quality of life measures in your data sets, but if you can find, maybe you can control them to explain more variance, because I don't have more hypotheses considering your exposition of your data to explain this decrease of health or these differences in the effects on health. If you consider some variables measured in a proper manner, maybe you can increase your amount of variance, your explains variance. But this is difficult, because in general, when I check this kind of data sets, it's hard to find a measure of loneliness or quality of life that reports validity or reliability in a good manner. There is no use. I'm not used to find this kind of measures. It's a pity, but I'm not used to find it. And the other thing that I thought, it's about the proxies measures. I used to read a lot of research that use proxy measures about depression, about moods of people with dementia, from the carers. And recently in our ministry, we have the chance to ask directly to people with dementia using the standardized measures. And we find a huge difference, so huge difference with the info that people with dementia report and from the proxy reports. And we spent more than 3 months trying to find a way to best propose the Likert scales to the people with dementia, and we found it. We're going to publish a method to ask to the people with dementia in a standardized ways their opinions, and we found a very huge difference. Like, for example, more than 50% of variance difference for example, in depression, in the symptoms of depression or in emotion, or even in the perceived quality of their status, like, for example. So this is all the things that I thought during your presentation. I like so much your presentation, because it's something new for me, because I didn't thought anyway that in the considering this framework in Spain or in countries like in Spain, that we share the rooms mainly at least with one person or more than two persons in the same room sometimes. I think the average is two persons now in the hospitals, but sometimes in the other facilities it's close to three maybe. So,
in nursing homes it's
yeah,
usually shared in three people.
Yeah.
Okay, interesting.
Yeah, so this is my considerations. I like some of your presentation. If you want to discuss a little this.
Yeah. Thank you so much. I really appreciate your thoughts. I think some really great points. I will clarify with the proxy, when I say proxy measures,
Okay.
I'm not sure if I heard you correctly, maybe I'm wasn't clear with what I meant by that. It's not that it's someone else other than the resident reporting it in that sense,
Okay.
not that kind of proxy, but more I just use the word proxy because I don't have exact measures of mood, but I'm trying to use what other measures in
Okay.
the assessment are there that might kind of indicate mood. But you're right. I wish there were measures of loneliness in these kind of assessments. If anyone knows of better ways to try and capture that using the minimum data set, or there may be a potential to link to other surveys, but then the sample size really, really shrinks down. But yeah, interested to hear if there's data in Spain that could be used to do a similar type of thing. I'd be really interested to see what the results would be.
I'm going to look for. I'm going to look for.
Yeah, please do and let me know. Thank you.
Sure,
Agustin,
you're
I think there
welcome.
are some questions in the
audience.
Yeah.
Okay.
Andrea was first, I think.
Yeah.
Thank you. My name is actually Annika Herr. I just got the link by Andrea, who's also in the room. So Annika Herr from Leibniz University in Hanover. And I realized that when I read about Medicare nursing homes in the US, I only read about the discussion of implementing double rooms. So now I'm learning that there are actually a lot of, or I don't know how many, that's one of my questions, like a variation in the availability of private rooms. So my first question is, what's the incentive of a nursing home to provide a private room for a Medicare patient? So can they earn more money? Are they obliged to provide a certain share of private rooms? Who tells them to provide the share of private rooms? Does this vary across regions? And so this first thing, yeah. So and then when you compare to, you're using now the comparison between private rooms and is it double rooms or even larger sized rooms that you're comparing to? And I would assume that the difference between private and double room might be smaller than between private and 3 beds or 4 beds, which might also be still in use. I'm not sure whether you can differentiate because you have a lot of observations, so you might be able. And then one result could be explained that people like to stay longer or do not leave earlier when they have a private room because they feel that they have good care and that they, since they are in the private room, they don't have the urge to go back to the family, but can stay in the nursing home as long as they need before they return, in contrast to a double room, for example. So it might be not be a bad sign that they stay longer. I don't know why there's higher hospitalization. I don't know, but this might explain why they stay longer.
Yeah, thank you so much. I think really great comments and questions, and I'll just start with your last one in that I'm not actually when I look at length of stay, I'm finding any effect of being in a private or shared room on length of stay. So there doesn't seem to actually be any. That was one of my hypotheses as well. So I think that would make sense, but at the moment it doesn't seem like they're necessarily staying longer. So yeah, I think in my head that's not necessarily explaining the results. And your second question, I think, is a great point around, are we comparing to dual occupancy rooms or rooms with 3 or 4 or more? I think there definitely are rooms with 3 or more in the US. In my data, the most common is 2 people or 3 people. I think that's really the real bulk of shared rooms. I think there's the small rooms that do exist with maybe 4 or more. But you're right, I hadn't considered. I should have the data to be able to look at heterogeneity in terms of that. In terms of, at the moment, I'm just comparing private versus any number of beds that are shared. So it could be 2 or 3. It's mainly 2 or 3. But I could split it. I could look at 2 versus 3. Absolutely. I think it's a great idea. And then your first question, I think a lot of really important questions that you asked, and I know I didn't get to go into too much background about Medicare and how it works. I think you're right. What is the incentive for them to have private rooms? I think in general, well, let me start by saying in my data, what I'm seeing is I'm estimating about 10% of rooms in the US in nursing home, 10% of rooms in nursing homes are private. So the majority still are very much shared, which I think is different to the hospitals here. I think hospitals in the US are much more, have moved to really private rooms only, mainly. But yeah, even that number doesn't exist really in another source. So I think that's what I'm finding. And what's the incentive for them to have private rooms? I mean, in terms of Medicare reimbursement, there isn't a differentiation here. So they're not getting paid more for having a private or shared room, which I think, yeah, is interesting in the sense that could be a definite policy lever if we did want to incentivize more private rooms. So, and they're not obliged to have private rooms. Yeah, Medicare at the moment only kind of reimburses at a base level for shared rooms. I think why might they have private rooms? Well, make themselves more competitive, maybe more marketable. If they think that older adults, or adults want to have private rooms, that's going to make them competitive. And particularly we know nursing homes in the US get a much higher reimbursement rate for Medicare residents versus Medicaid. So if they can provide more private rooms and appeal to, I guess, Medicare residents, that's one hypothesis. There does actually, I did find out they are allowed to charge residents extra on top of the Medicare reimbursement rate privately for a private room. So some nursing homes might be doing that, but from a lot of the people in nursing homes I talk to, that seems to be very uncommon. So I think the majority of Medicare residents are coming in and paying nothing out of pocket, and some might get a private room, some might not. But some nursing homes might be charging extra for the private rooms. The other reason why they might have private rooms as well is just infection control or clinical kind of care requirements that mean that they want to have private rooms, but at some point, if they have the room there, then maybe they'll give it to other residents. I hope that answered your question. I know that's a bit over the place.
Thank you.
Yeah, great questions. Thank you. Who was next? I'm not sure.
I think Nia.
Neve. Hey, how are you doing? I'm from Department of Health Ireland, and thanks very much. It's really, really interesting. Your research, just a couple of questions. You've answered one of them, where people are paying extra, so they're charging, in some cases, maybe slightly more. I'm kind of homing in on charges a bit in Ireland here at the moment that are being charged to our residents. But I'm also interested in staffing levels and the interaction, I suppose, between the staffing levels and the care outcomes. So you're looking at room configuration. I'm just wondering, if you had a fixed amount of money, would you prioritize private rooms, or would you prioritize increased staffing levels and skill mix? Where would you put the money for the best care outcomes? Or have you gotten as far as that yet? Am I kind of preempting something here?
Yeah, I mean, I guess my preliminary results, so I guess I'll caveat in that sense. And yeah. I haven't done any, specific analysis on that. All I can say so far is that my results are, if anything, suggesting that, definitely finding no evidence that private rooms are better for health, but if anything, in some cases, worse. And that's, I think I'm one of the first studies to look at that. So we don't really have a strong evidence base compared to a lot of work has been looking at, I think, minimum staffing levels and staffing levels. So I think I suggested, right at the end there that, I mean, my takeaway at the moment is that, it probably makes more sense to put the money into quality improvement initiatives that we know are going to work, that we have the evidence there for already. But I haven't specifically, done any comparisons or calculations or work really comparing the two. All right. I hope that makes sense.
No, that's good. Thank you.
Oh, thank you. Javier?
Yes. So I have two questions about the heterogeneity effect. So I'm not sure if maybe I missed it, but you list us several things that you could be looking at subgroup analysis, I imagine. So I'm wondering about two things. One is ethnic differences that could be, if you have the data. I'm just thinking about like a Hispanic living in the UK. Privacy is just a massive divide between people from Latin American origin and the UK. Let's say we understand privacy in a totally different way, especially in terms of health. So we will share everything we like to share. This is just obviously I haven't done research on that, but just basically we like to talk about all our illnesses and how your experience helped me with my own illness. So I'm wondering whether there are anything there that could be explored. And the other thing is about because if I'm right, you explore availability of private room rather than choice for private rooms. So I'm wondering whether there is a difference between people that have a mismatch of choice. So people that when sent to a private room, but no, sorry, when sent to a share room, but actually wanted a private room, compared to people that didn't have this mismatch. So it's kind of a combination between availability and choice, because for what I understand is so, but maybe you don't have the data, so I'm just wondering whether it's anything that can be done, like evaluate choice at the same time that evaluating availability, if that makes sense.
Yeah, I think it does. I think really interesting thought that I haven't thought deeply enough about. I mean, I definitely don't observe their preferences
You don't
in
have
any
to,
kind of
yeah.
in any kind of direct way. I don't think I have any data on, did this person want a private room or did this one want a shared room? I mean, I think I've thought about trying to use the word proxy for that in terms of, any kind of variables in the MDS that might indicate a preference for privacy or a preference. There are some questions that say, how much do you value having somewhere to take phone calls in private? Or, maybe could I use some kind of proxy like that? But I think at the moment that's the best that I have. If you have any other, I could think more about if there's any other way to kind of back out some kind of, preference. But I think a really interesting question.
I mean, using choice again, it will end up being more problematic, I guess. Now I'm thinking, because obviously will be some self-selection again, and it will add up to your selection issues, I guess. Because availability, you don't have a choice. You are just sent.
Yeah, that's right. Exactly. Yeah, I guess I'll think about it only as like a kind of heterogeneity later on. But exactly, that's why I'm using availability, because it is quasi-random. It's no matter what you want, whether it's available or not, is going to dictate whether you get it or not. So that's
just
the
thinking
idea.
about mood. Well, you don't have mood to measure, but whether you are going very unhappy going to that room because you didn't get the room that you wanted. I think that was the initial thought, that you will start going to the nursing home in a situation that is not ideal to yourself because you went sent to something that you didn't like. But yeah, I mean, difficult to measure and add other problems to the analysis, I guess. So maybe not very good idea.
No. Worth thinking about. And I think your idea about can I look at Hispanic ethnicity? I can observe that for sure. I think I hadn't realized that about what you said about privacy and Latin American ethnicities. So I could look at that, and I think that's
so.
really
I'm not sure about the American context, but in the British context, yes, there is a difference. The reason why I think Latin Americans will share more is because we have very poor kind of health infrastructure and services, and those that are available that are not free. So people try to save money, knowing from their friends and family, rather than going to the doctor because that will cost them money. So I'm not sure about in the UK, obviously, because there is public health. There is very big difference on that. So I'm not sure in the American context whether you will see that different too, but don't know.
Okay. Yeah, no, good to keep in mind. Thank you.
I don't know if there are more questions. Something in the
No.
chat.
Oh, is there?
Oh, Agustin put some questions. No, I don't think there is anything in the chat. But it's almost the end anyway. I'm not sure we have more time.
No
Well,
worries.
if there is no more question, I would just to thank Diane and Agustin for chairing and Diane for presenting. Thank you very much. And as I said, if you have any other work to show or any paper that you want to publish on the observatory, please let me know. I'm happy to do that. Or if you know other people that would be happy to present as well.
And thank you so much for having me. And thanks everyone for the great questions and for being here. Really appreciate it.
Thank you. It was very interesting. Thank you very much.
Thank you so much,
you.
Javiera,
Thank you,
Diane.
Naf.